So, you know, I am an integrative physiologist, and for cardiovascular physiologists, regenerative medicine is posing a new, and I would say, a very exciting challenge: how to study function and metabolism of regenerating tissue. Not only a challenge for cell and molecular biologists, but also for us. So my contribution will be in this sense. And to explain to you why I consider this a challenge, interesting but still a challenge, 4 weeks later, what we found when we assessed the ejection fraction, that ejection fraction in the stem cell treated infarcts was essentially identical to what we found in the control infarcts in which we injected simply PBS, so a physiological solution. Why is that? I mean, if you consider this value here, and it's not indicated here, but it is more than 60%. So it is almost, no, I mean, it is physiological. And why? Because we generated very small infarcts in order to minimize the mortality of these animals in the perioperative period. Our aim was not to generate large infarcts. We were not interested in that. We were interested in proving the principle, the concept that these particular stem cells were working. But based on this parameter, on ejection fraction, the question that can be prompted is, was there any effect of stem cell delivery in this particular case? So I will go to a second example. This is a very famous study performed published some years ago by Professor Zay's group, the REPAIR AMI trial. So they infused bone marrow stem cells in coronaries of patients 3 to 5 days after myocardial infarction. And 4 months later, when they studied, when they evaluated ejection fraction, they found that there was a statistically significant difference between the treated group and the control group, the placebo group. But if you look at the absolute value here, so the absolute numbers, the difference in ejection fraction is really small, is a few units, few percent units. But also in this case, look at the ejection fraction these hearts were starting from. Almost 50%, so almost at the borderline between normal and the pathological ejection fraction. So not similar to the pigs that I showed you, but close. So also in this case, the question that is prompted is, minimal functional effects of stem cell delivery? Difficult to say. I'm not here to evaluate that study, but what I'm saying is that based on that parameter, on ejection fraction, the question is that. But it is difficult to draw conclusions because ejection fraction is an index of global cardiac function and is quite limited. It is limited, as you know, because it is very much afterload dependent. So it's a very coarse index. But in addition to that, this is not my point. My point is it is an index of global cardiac function, whereas cardiac regeneration or repair or whatever is a regional phenomenon. This is important. And therefore, its correct evaluation needs regional functional measurements. Otherwise, the effects of regional therapies might be underestimated, especially during the initial follow-up period. And when I say the initial follow-up period, I mean at least the first 4-6 months. So the question is, how to study regional cardiac function? How? With what I would consider the powerful magnifying glass of cardiac multi-imaging, I would say multi-imaging, so combined techniques of imaging. So the questions that can be answered by MRI in vivo. What is the extent of myocardial infarction? Is tissue regeneration improving regional contractile function? Very important questions, and they can be addressed in vivo with no need of invasive measurements, and so ideal for a follow-up over time, because you can repeat the same analysis over time. So let's go back to my study in pigs in which we induced that myocardial infarction, as I showed you before. So the ejection fraction, as I said, if you measure that, the infarcts were very small. There was no significant difference between control infarct and stem cell treated infarcts. But when we assessed the extent of myocardial infarction by using delayed enhancement with gadolinium, with this particular contrast medium that is utilized in MRI, first of all, we found that indeed the extension of myocardial infarction was very small. But with MRI, you can do something more than that. So this is better visualized here in this short axis view. In the gray scale of the MRI, you can not only quantify exactly the extent of myocardial infarction, and so you can determine it based, on a volumetric assessment, but you can also quantify the so-called core zone, here translated into a color scale. This is the magenta, and the gray zone. The core zone is the real fibrotic tissue, is the real scar. The gray zone is the area in active repair or regeneration or whatever. And it is interesting also clinically because it has been associated to the foci of arrhythmias. So it is a good thing to have regeneration, but at the same time, this gray zone, it has been associated with the foci of arrhythmias clinically. So you can quantify these very well. In fact, despite the non-statistical the significance here in the difference between ejection fraction in the two groups, we found that the infarcts were in fact small, something like 13% of the ventricular mass. But in the stem cell treated hearts, the infarcts were 40% smaller using MRI at 4 weeks. And there was also a nice correlation between what we found in vivo and the ex vivo analysis of the border zone that we identified using those stitches, as I showed you at the beginning. And the border zone of the control infarct was much more fibrotic compared to the stem cell treated infarct, in which we saw many more vessels and other viable tissue. This is a normal heart for comparison. And also the core zone was more than 50% reduced in this particular, after this particular treatment. But MRI can do more than this, obviously. So not only morphology and size assessment. Tagging MRI is what you need, is one of the methods that you can use in MRI to evaluate regional cardiac function. And this is the principle here. You introduce lines of hyperpolarization that will literally slice the tissue, in this case the heart, forming this grid here. And the lines will follow the motion of the ventricle during systole and diastole. So you can subdivide the ventricle into many small segments, and so you can follow the contraction of these segments during systole and then the relaxation during diastole, depending on what you want to study. And you can generate, by subdividing this in many segments, curves that will quantify exactly, for example, in this case, the ventricular circumferential shortening during systole. You can do something even more sophisticated. Look at the colored lines. So you can subdivide the wall into epicardial, mid-myocardial, and endocardial layers. And conventionally, a good contraction here is indicated by a negative % value. And see, over the 6 segments that we consider here, the contraction was, contractility, regional contractility was uniformly good. And this is a case of myocardial infarction. You can already tell by eye that the wall motion is quite different from this. And looking at the same exact segments, you know here in this case that segment 1 has a flat line, so it is not really contracting. In some cases, you would have a paradoxical motion here. The value would be positive. Same thing with segment 2, which is impaired, and segment 6. So here, there is no space for qualitative analysis. This is quantitative analysis. So you can subdivide this even in more segments, and so determine the regional contractility in each one of them. What we did in our study was we used this approach, which I think is quite convenient. We subdivided the heart into 12 sectors. And we started from a hallmark here, that in this case is an anatomical hallmark, is the junction between the right ventricle and the left ventricle at the anterolateral wall. So starting from here, we could generate curves of contractility with 12 points. And each point corresponds to the contractility for each single segment here. And this is a very convenient approach. Why? Because you don't know exactly where the stem cells went. You don't know exactly where the regeneration or repair is occurring. But if you generate a curve that scans the whole circumference here, then you can identify the segments by interpolation. And this is in fact the case. So this line here is the normal heart, 12 points, contractility uniformly good along this. And see, this is a control infarct here. And segments 1 to 5 or 6 very much impaired. The contractility is much smaller. There is a significant difference here. So you know exactly in which segments this dysfunction is occurring. And this red line here, this is the stem cell treated infarct. The line C is not normal yet. You cannot superimpose it to a normal heart. But there is already a divergence compared to the control infarct. And some segments are already significantly different in terms of contractility, especially 3, 4. So you know where the improvement in function is happening. In fact, segment 1 here, nothing is happening here. The 2 points are superimposed. And guess what? We never reached with our syringe for injection that segment for stem cell delivery. So we know exactly, again, the points where everything else is occurring. The rest of the heart is pretty normal. So the questions that can be answered by post-emission tomography in vivo. Is the regenerating tissue normally perfused? Is the regenerating tissue metabolizing energy substrates? 2 other very important questions for physiologists, but I would say for clinicians as well. PET is a technique of nuclear medicine, so the principle is always that. So you infuse in the organism a radioisotope, in this case a positron-emitting isotope, and this isotope will be taken up by tissue with the scale of intensity based on the amount of isotope that is taken up. Here, this signal void here indicates that there is no uptake. In fact, this is a heart and there is an infarct there, so there could be no uptake. By using positron emission tomography, we can generate these maps, these representations here, and going from the apex to the base is flattened. See, I mean, this was our study. The signal void here around the apex for flow, left panels here, and glucose uptake, right panels. So flow, so you see that the signal void is much bigger here compared to the transplant, the hearts transplanted with cells. And we use radioactive ammonia to measure this, a very well-established method, I mean, years and years. And for glucose uptake, we use a glucose analog, deoxyglucose. It's not a real good index of glucose metabolism, but it is good enough to indicate that tissue there is, in fact, taking up glucose. You see, this signal is much smaller here. We subdivided the ventricles into 12 sectors, again, as we did with MRI, so that we could make a back-to-back comparison. And also in the case of positron emission tomography, 4 weeks later after myocardial infarction, this is flow in a normal heart. See the difference between this and the control infarct, and see the line here of stem cell-treated infarct. Once again, the line is not normal yet, but there is already a significant difference in the same regions where we found an improvement in contractility. So everything is consistent there. Same thing with glucose uptake. See, this is normal. This is the pathological. Here there is a difference in those segments, but look, I didn't put any symbol here. There was no significant difference yet. And this is an important concept. You might have, at least during the first phase, a regeneration of some tissue, but not necessarily, and perfused tissue, but not necessarily that tissue is already a tissue that is metabolizing as you would expect from myocardium. And you can detect that using positron emission tomography, looking at the metabolism of energy substrates, something that you would not be able to do with any other technique so far. But now I want to show you something that is not common. This is a little bit uncommon, a new frontier. So how we are trying to measure cardiac energy substrate metabolism now, not only with PET, but even with MRI. And you need this type of equipment here. I would say that, I think, to my knowledge, only Pisa and Toronto have this expensive thing here, the polarizer made by Oxford Instruments. And this is an agreement with the General Electric Health, so with the collaboration with Munich, in which the engineers are developing these systems. So I'm saying 2 centers for use for cardiac use in large animals, because there are other centers that are using this for small animals, obviously. What is the principle of polarization? So the reason why you have a signal in MRI is because in a magnetic field, the nuclear spins will align parallel or anti-parallel to the magnetic field. And the reason why you get the signal is because the number of nuclei that are in parallel are a little bit higher than the number in anti-parallel alignment. With the hyperpolarization, you magnify the signal a lot because you increase tremendously the number of nuclei that are aligned in the parallel position. So you can have a higher signal. In the common MRI, the nuclei are the hydrogen nuclei of water. Here, the story is different. So you hyperpolarize the nuclei outside of the MRI, and then you run to the animal or to the human being to inject this substrate once it is hyperpolarized, because this state will disappear quite quickly. So you inject that, and what we labeled was substrates with the 13C. Very convenient, because with 13C you can, for example, label pyruvate, which is one of the substrates of the myocyte. Once pyruvate enters the cell, it can be rapidly converted into lactate, a little bit into alanine, but in the normal perfused heart, it will be fully oxidized into the mitochondria to form CO2 bicarbonate. In fact, this is the idea. By labeling pyruvate, then you can follow the metabolic fate of this particular substrate, and so you can detect the production of lactate, alanine a little bit, and especially CO2. In MRI, this is, once again, these are images. I mean, this is a study that is now submitted. These data were presented last year at the American Heart Association. See, this is a heart, a pig heart, in which we caused a transient occlusion of the LAD and with the relative signal void. And this is lactic production from pyruvate in the normal perfused heart. Remember that even in the normal perfused heart, the heart produces a lot, I mean, the myocardium produces a lot of lactate, so normally. So that's why you see this big signal. And see, no signal here because there is no blood reaching the ischemic area. Very nice correlation then between these in vivo data and the ex vivo finding when we, I mean, this is a classical method of ink injection during coronary occlusion. We identified the area at risk. So there was a nice correspondence between the in vivo and the ex vivo data. And we could even generate a map similar to the one that I showed you with post-emission tomograph, in this case for bicarbonate, so CO2. So we know here that in this ischemic area, the heart is not generating any CO2, so it's not metabolizing, it's not oxidizing pyruvate. So this is really a frontier that will help, in my opinion, a lot also the field of cardiac regeneration. Next will be 13C acetate, which is even more interesting, I would say. Acetate is metabolized in the Krebs cycle, so you can follow then the metabolites, the intermediate metabolites of the Krebs cycle, and finally CO2. But the work here is in progress, and I hope that you will hear from us soon in this regard. Last few slides, just to show how MRI is useful also to track the fate of transplanted stem cells. How? We transduced stem cells ex vivo with a lentivirus carrying the ferritin gene. If you have expressed ferritin in the cells, then this will lead to the accumulation of trivalent iron. And this accumulation here can be detected, for example, by using a specific coloration, Prussian blue. And see, you see this blue color. We found that this is absolutely harmless for cells. It will not affect it. So just a simple accumulation of this type of iron. Then we injected these labeled cells into infarcted rat hearts. And we analyzed this in MRI once again. And this is a 1.5 Tesla, simple, very standard MRI. And if you look here, this dark area that becomes larger and larger, this is the iron accumulation that you can detect by MRI. And this is in the scale color. So this technique is very interesting because at the same time, you can identify the area, the infarcted area, as I showed you before. You can identify the localization. You can track the stem cells that have been injected. And you can also do the classical, functional analysis that you can do with MRI. This is better seen here. See this dark area in the short axis view in the color scale. This is the accumulation of cells carrying iron. Ex vivo, when we did the histological analysis, we found those cells, in fact, accumulating iron. They were no longer stem cells. In this case, we used cardiosphere-derived stem cells, but once again, only for the purpose of the methodology. And we found those cells of pig origin because we injected pig cells into rat hearts. And they were accumulating iron. They were cells, viable cells. And the effect of this particular stem cell therapy was absolutely identical to what we found with non-labeled stem cells. It's very convenient, this, because it gives you the possibility to track stem cells even after their multiplication and differentiation. You know, we are using a lentivirus here. And lacks of the toxic effects previously found with iron particles, because so far what they have been using is loading cells with iron particles, which in the long term are toxic, but especially you cannot follow them because once the cell divides or differentiates, you lose them. This is an alternative to that. So this is my final slide. So this is the physiologist's dream, at least in this area. one technique, very likely MRI so far, maybe something else will come later, for all the measurements at the same time: morphology, function, metabolism, and cell tracking. As I showed you, everything can be done with one assessment using one device. So I should acknowledge many people, but in particular will acknowledge these collaborators. Dr. Vincenzo Leonetti, a faculty at the Scuola Sant'Anna, who is really the driving force behind this. And then Acquaro, Menichetti, Neglia, Lombardi, who are really world experts in post-emission tomography MRI at the Institute of Clinical Physiology of the National Council of Research in Pisa and Fondazione Monasterio. And then Professor Ventura, Professor Pistello, they helped me with stem cells and also with the lentivirus. So thank you very much for your attention.